Welcome to the Diabetes Podcast, where we look at all aspects of type 2 diabetes and provide real, proven strategies for not just managing the disease, but putting it into remission. Imagine this. You walk into your doctor's office, terrified. You just found out that you have diabetes. And in less than 15 minutes, they hit you with, you need to change your diet, exercise more, we'll start medication if your numbers don't improve. And then you're out the door. No roadmap, no answers, just confusion, shame, and a follow-up in 3 months. And when those numbers don't improve, instead of a plan, you get more medication. Instead of support, you get silence. Instead of hope, you get stuck. Today on the Diabetes Podcast, we're discussing the real reasons so many people fail to reach their goals, even when they're trying. It's not laziness. It's not lack of willpower. It's clinical inertia. And it's costing people their kidneys, their eyesight, their mobility, and their freedom. If you've ever left a doctor's office thinking, now what? This episode's for you. Let's get into it. Hello, and welcome to the Diabetes Podcast. I'm Richie.
And I'm Amber.
And Amber, today we're talking about something that I think everybody in our audience has probably experienced, which is the story of how I found out I had diabetes and how things really got off to a bad start from go.
Yes.
And then maybe some opportunities for those folks in our audience to start moving things forward in a positive direction. And certainly for those that are newly diagnosed, how to really get a solid start on putting this thing into remission. So Amber, can you tell us, in your experience, and let me frame that experience, in your greater than 20 years of experience specifically in the diabetes care space, what's the normal way that people find out that they have diabetes, specifically type 2 diabetes?
Mm-hmm. Usually the MA, not often a registered nurse, but sometimes, will call the patient with lab results that they were given to do prior to the appointment. And they're told that they have diabetes, that they need to come in for an appointment. Because usually you're doing your annual physician visit. You're just trucking along once a year, seeing your doctor. You get your labs done before or after the appointment, and then you get some follow-up call regarding those labs. So you're not even surrounded by support. You're not with anyone that can answer questions that you have right away. So people go directly to the internet and Google, I was just diagnosed with diabetes, what do I do? And that's where chaos ensues. That's just really the best summary that I have for it. Okay. It's just so much information. We are in at a time of information without a lot of discernment and consolidation.
Okay. Why do you think that is?
Ooh, it is just...
And that may be beyond the scope of this conversation.
Yeah, like that's a very broad question.
Okay, better question. And maybe a little bit more specific question. Mm-hmm. What's preventing general practitioners, because at this point you aren't talking to an endo.
Yeah.
What's preventing general practitioners from doing better at the rollout of you've got diabetes?
I think you have to look at the number of patients that are underneath the general practitioner's care. And that's right around the 1,800 to 2,000 people mark. And physicians are addressing about 6 health concerns from their patients per visit in less than a 16-minute window of time, which is, if you really think about it, that's astronomical to cover all of the things that need to be covered in such a short amount of time. And so it just doesn't leave a lot of time for specific education, especially with diabetes.
Yeah, I got less than 3 minutes to talk about your diabetes. Let me make all of the changes that are necessary to do this. Let me get that into what's effectively an elevator talk.
Yeah. And so a big issue that stands out is this idea of clinical inertia.
Okay.
And like to define that, it's when a provider fails to initiate or intensify treatment. So there are standards of care in diabetes. And when treatment is indicated due to the A1C results, then oftentimes the provider doesn't progress that. And it's not because these doctors are careless. It's not because they don't want their patients to get better. That's the goal of every provider I've ever met. And I've met a lot of and have plenty of conversations with doctors. And it's really, number one, the short visits that I was talking about with the multiple comorbid conditions, if you will. So there's not just diabetes, it's heart disease, blood pressure, their toe is doing this, and then they want to talk about the weather, any number of things that come up. And then it's a joke among healthcare providers that like the main thing doesn't get brought up until the provider like goes for the door to leave. And that can get providers behind schedule and then get even more rushed for subsequent visits. And then within these visits, you've got competing priorities. Which is going to do this patient in more immediately? Is it the blood pressure 185 over 90? Yeah, that's more pressing than type 2 diabetes in this moment.
In a past life, this kind of sounds like triage.
Very much so.
I can't fix it all. Who's the person that needs my attention the most? Who's the most urgent person on my schedule? And then that person's going to get all of the attention, all of the resources. And I think very often, at least as it relates to the initial diagnosis of type 2 diabetes or prediabetes, that person is like the last on the list because it's not urgent. It's important, but it's not urgent. Is that fair to say?
That's fair. And it's not just that, it's what gets brought up during the visit. If you've seen 12 other people so far that day and you're a little more tired, less sharp towards the day, and you're seeing someone with type 2 diabetes, but they're talking about how their house was flooded or something else negative happened. Doctors are typically quite empathetic individuals, and they're trying to sympathize with what's going on and see what kind of resources might be available to that person. And the diabetes is going to take a back seat to just how do you live day to day with that going on. It's not like, yeah, your house is flooded and you have some food insecurity, but let's get you on this diet plan. And it's a challenging thing to juggle all of the conditions and things going on.
Yeah, we can't even have a meaningful podcast in less than 16 minutes. How can your doctor effectively come up with personalized strategies for success in that amount of time?
And sound like they really care, because it's easy to be like, okay, this is what you're going to do. But to get patient buy-in for what they will do and what they can do and what resources they have, that's a whole another level of things to take into account and consider. So like in an ideal world, if you will, if we can dream for a minute, that person would, so they'd be identified as having prediabetes. Really, that would be the space. But even if it is type 2 diabetes, there's immediate personalized nutrition and lifestyle support. And that part is very lacking, especially in rural communities. Just in general, it's lacking. Yes.
Why do you think that is?
Multitude of reasons. Number one is I worked in a past life, again, as a diabetes care and education specialist with a hospital, and we provided outpatient and inpatient diabetes care. So outpatient is the patient schedules an appointment and they come in and they have an hour visit. We also had diabetes education classes, which were always encouraged to be in group settings because even though the reimbursement per person was less, the guidelines for payment said that they would pay for a group session and an individual session. And then after that, that was it. That's all you got for diabetes self-management. But you could also do medical nutrition therapy if you were a registered dietitian. Yes.
So if I can read between the lines, we're talking about basically what insurance will pay for.
Yep.
Whether that be private insurance or whether that be Medicare, Medicaid, all that other kind of stuff. The hospital is not, sounds like, financially incentivized to provide this level of care.
That's
is that fair?
Yes. And when I started at that diabetes center, they were not running in the black. We lost money. And many times hospital organizations will lean on cardiac care, will lean on those departments to fund these other lesser departments. But it's challenging to make that a profit center. And if it's not a profit center, most hospitals that are for profit, right. The hospital I worked at was not necessarily for profit because they were safety net and had some federal funding coming in. But most for profits don't have these programs established robustly because they're thrown together from people that recognize a need and doctors that demand this for their patients. So there are standards of care within that, and it's recommended that you have a physical therapist and a dietitian and a nurse and a pharmacist and occupational therapy, this well-rounded group of individuals that are going to look at different aspects of diabetes care. But we were all dietitians. We had one nurse, and sometimes we would have a pharmacist come in and talk because it's very challenging to get a very well-rounded program.
But I think still it comes back to, certainly in your circumstances or in your experience, that whole section was not a moneymaker for the hospital.
Right.
Probably beyond the scope of this podcast. Is there a cure for that other than we're going to stop focusing so much on for-profit healthcare and start looking at healthcare as, I don't want to say human right, because that's, anyway, I don't know that as long as healthcare in general is tied to profitability, that patient care is ever going to get better, or at least patient-centric. That's not the mission. That's not the mission of our current healthcare system. It may be part of the doctor's code that they're going to do no harm and try to provide the highest level of care that they can. But I think we need to be very candid about doctors aren't running the show. Hospital administrators are running the show.
That's an excellent call out there. Yeah. That's a whole other political, social, public health issue. Absolutely. And I can speak for myself and my mindset when I worked in that position. And it was people need education. So it was just this big education dump when you came to the classes. It was A to Z, foot care, blood pressure, learning about sodium when you eat out, like all of this stuff. And then we did do some goal setting, but in terms of like real monumental forever change, I can't say that that was the focus. Like, we like to believe that it was, and we tried to do that, but I wouldn't say that I had the skills at that point in time, even though I'd been in diabetes for 6 years at that point. I didn't have the skills to bring about real change. Now, we did do outcome studies, and we did show an A1C reduction of about 1.2% on average for the people that we saw, which is about like a diabetes medication. So you could argue how successful it was. We didn't have long-term stuff, although long-term outcome studies have been done. And that's exactly why diabetes self-management programs are even paid at all by insurance companies, because there is a good return on investment for those programs. If not, they wouldn't fund them.
But it's still very much, how much information can I cram into the amount of time that I'm directly financially compensated for by insurance?
Yes. 100%. 100%. Because we did 2 3-hour classes, and they were like, can you imagine 3 hours of nutrition, diet, exercise, cramming 2 days back to back? People were just completely overwhelmed through that. And most of them did not follow up for the one-on-one piece, which leaves them just with their heads spinning.
It would be very much like listening to this podcast for 3 hours straight. It's just a lot of information, and not being able to go back and re-listen and pause and take notes and that kind of stuff. It's just stuff's going to get missed. I just can't absorb information and permanently retain that information that fast.
Exactly. And they might leave gung-ho and do some really positive changes for a bit of time, but eventually old habits die hard, and people sink back. And the sad fact about type 2 diabetes is that it is a degenerative disease, all things remaining the same. So unless you kick it up a notch in multiple areas, it's going to continue to get worse because of it just is what it is. And I think an important thing to stack on to this idea of provider visits when people go in and they're newly diagnosed is that 1 in 3 people with type 2 diabetes misunderstand their treatment plan after they have a standard visit. And that's from Diabetes Spectrum and from the ADA. And more than 60% say that they left their appointment without clear guidance on what to eat or what to do. And I hear this all the time. Just tell me what to eat. Just tell me what to eat. Just like people are chomping at the bit. Just tell me what to eat. And okay, eat this. It's not that fast. It's simple, but it's not easy. And we've said that time and time again, but it is so true.
So for the clinicians in our audience, from your perspective, is there any low-hanging fruit way to improve that?
What has typically been done in the past with minimal success is don't eat any white foods, eat less, exercise more, just those sort of cliche, broad strokes guidelines. The specificity is really what is lacking. And there's no time for that. Physicians are brilliant, do not get me wrong, but they don't have the nutrition expertise for the most part to be able to really elicit change in people.
Okay.
So let's talk about what the scope is of this. Is this a one-off thing, or is this something that happens pretty consistently across the board? And I want to talk about how much clinical inertia is responsible for delayed treatment. So 80%.
You said 80?
It is responsible, yes, for 80% of treatment failures in type 2 diabetes. So what that means is action is delayed, diluted, dismissed, and had earlier decisive care been given, meaning like nutrition and education support, medication intensification as recommended on the clinical guidelines, then 80% of people would not have failed to reach their A1C goals.
Trying to process what you just said. I'm going to ask for clarification. I don't know that I'm going to get this right. If we, and by we, I don't mean you and me, but the American healthcare system can get this right, are you suggesting that we can reduce this by 80%?
I don't think you can turn it quite that way.
Okay.
Because I really wanted to be clear also on what that 80% meant. It really is specific to that A1C goal. Like 80% did not reach their A1C goal that could have, were it not due to clinical inertia.
So let me rephrase my question then. We're not talking about remission at all. What we're talking about is it's just not getting worse and maybe slightly moving in the right direction towards what is, and I'm doing the air quotes, managed diabetes. My type 2 diabetes is under control. Again, also air quotes.
Yeah, clinical inertia is not focused if when that happens and occurs, it is rare that someone is going to achieve remission. Absolutely. Okay. And you have this vicious cycle where you have medication piling up like late in later stages without any kind of a metabolic change. And the last 12 core defects that we talked to were about the metabolic changes that are occurring. And so like you've got a more reactive approach as opposed to proactive. So you've got your metformin and then a sulfonylurea like Actos, GLP-1 and insulin, but you're not fixing like the root issue. Like sulfonylurea and Actos can work a bit on the insulin resistance, as can a GLP-1. But like the typical course is metformin, and then something like Januvia, and then maybe Jardiance, which is an SGLT2. So none of those are really, truly going to combat insulin resistance. And none of those are going to be as strong and powerful as nutrition and exercise lifestyle changes.
So what I think is probably not happening, maybe ever, is the effective communication of diabetes as just a metabolic disease.
Yeah.
If we don't address not just your metabolism being dorked up, but what are the behaviors that led to your metabolism being dorked up, and how can we address those? I don't understand how you could ever be successful under those circumstances, because just full stop, the medications aren't that good.
That's what the doctors have in their toolbox. That's what they're trained on. And you have to also consider that visit. And I know if you're listening and you think about any conversation, if you have type 2 and you think back to conversations and bargaining that has happened with your physicians, patients say things like, I'll try harder. I promise. Give me 3 more months. I'm scared of insulin. Can I do anything but insulin? What else can I do? And it's a tough, like to say it's tough is such an understatement. You have people who are experiencing this for the first time and they want to try diet and exercise. And you have providers who have had these conversations over and over with people, and they see that the vast majority of people are not going to be able to make the level of changes needed. And so they push back to put them on meds, and the patients are mad at their doctors. They just want to medicate me. They don't care. And it's not that they don't care. They're seeing it from a completely different perspective. They've seen it all the way through to the end. Because right before that patient, they talked about somebody's toe ulcer and the fact that they might be at risk of an amputation. So they're seeing the whole spectrum that the newly diagnosed person isn't seeing, yet that clinical inertia is still there. It's astounding. So I also want to point out, when it comes to A1C results, the UK PDS study, which is really landmark, that came up with this 1% rule. And what that means is for every 1% of A1C above 7 that a person has, they're at 21% higher risk of death due to diabetes. They're at 14% higher risk of heart attack or myocardial infarction, and they're at 37% higher risk of microvascular complications. That's your kidney disease, your retinopathy. And an A1C of just 9, let's say we're 2 points higher, that doubles your risk of kidney failure, blindness, and stroke across time, among other things, diabetic neuropathy, all of that. Those are not fun statistics. That's not the fun stuff that I like to talk about. It feels like scare tactics at times, and it's not. It is the reality of diabetes that I've seen across 20 years. What I've seen with the doctors and the spectrum of what they've seen, it's the same thing. I see people that are absolutely fine. They stepped off the ledge of a deck wrong. That was on a Friday. By Monday, they've got a below knee amputation. By Thursday, they've got an above knee amputation. And it's really an ugly disease. I don't like it. to
Yeah.
say the least.
So
Or do the people listening like, I know, right?
Preach
Like,
on,
preach
sister.
it. I know. It's amazing. And most people that I talk to, they want to get off of meds when the reality is that 50% of people with type 2 diabetes are on multiple meds within 5 years of the disease, and a third are on more than 3 medications. And that's from the NHANES data. That's the huge study across time, looking at behaviors of individuals, what they're eating, medications that they're on, satisfaction with different aspects of their life. Just people on meds that they don't want to be on, but they need them to control the A1C because the nutrition, lifestyle, activity portion is not up to snuff for a multitude of reasons as well. And the truth is, there is a best window for remission. This is the really insidious nature of clinical inertia, is that we are on a time crunch.
Right.
Every delay by 6 to 12 months can significantly decrease remission potential. And the DIRECT trial, which is a huge trial really looking at remission, is that the best rates of that are within the first 1 to 3 years post-diagnosis. And then it gets cut by more than a third after that. Not that people can't do it. It just becomes more challenging.
Again, not the most savvy person in the entire world, but I'm guessing this is tied to my beta cells. This is tied to the cells that I have that are capable of producing insulin are what I would say. We talked about triage earlier. If we can effectively communicate to clinicians that from a triage standpoint, the whole patient may not be urgent, but those beta cells are urgent.
Yeah.
And there's a need to communicate. Shoot, how do you tell people what their beta cells are? I didn't know that prior to doing this podcast. It's really, again, not trying to condemn general practitioners, but
Please don't.
But have to communicate. Your pancreas is in need of urgent care. That's basically what it is. If you are at diagnosis of prediabetes
and it's not
or
just
type 2
the pancreas, because we just did our 12 core defects. They're talking about
at that moment of diagnosis, the most urgent thing, the most good that we can do is to save as many of those guys as possible, because
beta cell preservation
for
is
best
urgent.
Long-term outcomes, that really is the time-sensitive piece that's not being communicated at all, I don't think.
And the cascading effects of insulin resistance, because we've talked on our podcast before about how it's a snowball effect of worsening metabolism in that too. And then people don't have the energy required to move. They're not having the energy to walk. They're feeling envious of people who can go to the gym and do things because of the mitochondrial dysfunction. There's so many things.
Yeah.
It's not just this one thing. And that's what's hard to address in a short visit. You cannot pick open the doctor's brain and have them really get across to you what they have seen, what their experience is. And even having seen and experienced that, they often do not know the way out beyond medications. And that's the take-home piece.
I asked the doctor what works, and he replies with, candidly, in my professional experience, nothing works.
Isn't
this
that
always
like,
gets worse.
Can you imagine?
Yeah.
Can you imagine you're going to and I've heard this multiple times, you're going to your doctor for help. You're going to your doctor for strategies, for answers, and they tell you, I cannot help you anymore.
Nothing.
Like, this is it. And you're either going to accept it or you're going to revolt against it. And even if you revolt against it and you turn online, there's tons of information, and most of it is misinformation. And even the good stuff, how do you consolidate that into a plan that's going to work for you? Those are the challenges.
Okay.
Some of the many challenges.
So that leads us into what I think the next logical question is, what actually works. And this is really two things. And I'm going to speak to the first one just because I feel it needs to be said, but I don't know that until our society is willing to accept the fact that we currently have a system that is not effective in treating diabetes because there's no financial return on this investment.
Yeah.
Until we as a society are willing to accept the fact that we are the ones paying for not taking care of diabetes.
Absolutely.
Like a sick population, the cost is we bear that cost.
Absolutely.
You know?
Absolutely.
I don't think we're going to solve that on this particular podcast, but really
it'd be fantastic.
The opportunities for compassion at scale. How do we realize that we have to fix this? Big we. We will continue to perpetuate this as long as we ignore that our brothers and our sisters are suffering and they don't have to. Yeah. So that's the big picture, long-term fix is we as a society start prioritizing behaviors that make the likelihood of this disease less.
Yes.
And for those that are currently affected, help to actually meaningfully promote healing. That's the big picture. The smaller picture is more for the people that tuned into this particular podcast.
Yes.
My physician doesn't have a lot of strategies or time really to help me in a meaningful way.
Yes.
I'm going to have to do this myself.
Yep.
What can I start doing today? Not this week, not this month, or before my next doctor's visit. What can I start doing now to set me up for success at my next doctor's visit for the following one and all this other kind of stuff?
Right.
Start making meaningful change right now.
Yeah. So if we took diabetes, nutrition, and exercise, if we took that and we looked at it under any other lens, let's look at it from a financial lens. You might have a financial advisor. You might have some IRA, some stocks and bonds. But day-to-day management of your finances, who's in control of that?
Yeah.
Your health is too important to leave it to someone else. Your health is your health. One of my saddest, but favorite sayings is ignore your health and it will go away. This is the time to take the bull by the horns. This is it. This is your life, your one big, beautiful life. And the question is, are you going to leave it to someone else or take care of it yourself? And so many people are like, I'm going to take care of it myself.
So the answer to how do I combat clinical inertia is literally take the ownership for the success of the program out of the clinic. It's what it sounds like to me. Like this place is great and they're doing the best they can, but really is never going, at least right now, unless things change a big infrastructure that we can't,
but you're paying your health insurance and you're paying them your copays and they're the ones that are supposed to management. And with that mindset, it's likely that person believing that is going to stay stuck.
Yeah. The work and the behavior is going to have to take place for now outside of the clinic.
Yep.
Okay.
Absolutely. And we could keep going, but probably we need to wrap this up.
Yeah. It's been a minute.
I've enjoyed it.
Several minutes, really.
It's a good discussion. It's one that we will continue beating this drum. We will continue having these conversations.
Okay. So if we can, to tie a big bow on it, really, clinical inertia exists. It does not mean that doctors are evil or do not care.
Right.
But it does mean that the traditional path of healthcare, at least in the United States, is not going to be effective. So
not going to be as effective as you need it to be to get the heck out of this disease.
I would say just not effective, period. If you do a thing and it continues to get worse, that's not effective, right? So effective to me is my numbers get better every month, every week. Like if I'm not seeing regular progress,
if you're caught in a riptide and you're swimming your heart out and you continue to get pulled further and further out to sea, at some point you have to realize you need rescue. Like you can take this and extrapolate it to any other thing and it's so clear. Yet it's amazing to me, for whatever reason, with diabetes, it doesn't feel as clear to people.
Okay.
I'm not sure why that would be, but it is, I've noticed.
But there is hope.
Absolutely.
There is hope. Again, type 2 diabetes remission is real. And the only thing really that works without some pretty nasty side effects is behavioral change.
Yep.
To take what I believe the physician's original guidance was, to start getting a better handle on what you're eating and to start increasing, you say exercise, but really that translates to movement.
And when we're talking about practical steps, because we always want somebody to come away from practical steps, so that if we just distill some things we've talked about in other podcasts, after you eat, walk 2 minutes. That's just, and see, this is why it's hard to give broad strokes general information, because if you're already doing that, you're like, oh, that's silly. How's that going to help? But for the person that isn't doing that, it can make a huge difference. So it's really important to just really take an assessment of where you are, how you're moving, how you could possibly move more, how you could possibly change some diet things. If you're adding sugar to your food here and there, where can you stop that? Yeah. What are you willing to change? What aren't you willing to change, and why? Just really examining a lot of those things. How are you sleeping? What's your stress level like? So just first take an assessment of where you are. And second, looking at small things you can do to try to make a big difference. And we're here if you need further help.
Yeah. Continue to use the podcast. Free resources, guys. Can't stress that enough. Always free resources. And at least as it relates to this podcast, in the context of everything that we're going to tell you is with the big overarching mission of getting better, not going in the other direction, actually measurably blood sugars coming down, A1C going down, body composition getting better, gut health getting better, all of that kind of stuff that leads to your best possible outcome, regardless of where you're at on your diabetes journey.
I want to add something really quick that I just thought of. What typically happens is someone will have a visit with their provider, and every single time it's like 7.2, 7.2, 7.4, 7.2, and then that next visit, 8.2. Then 9. And then they feel like they're just treading water, that nothing they do can get them back. And that is what we're talking about here. That is exactly the space in which we're talking about clinical inertia. It might not feel like inertia if the A1C is the same, but I want you to remember this is a degenerative disease, meaning all things remaining the same, it is getting worse.
So again, keep listening to the podcast. Please subscribe. That helps to get our podcast before a bigger audience. The audience is huge, guys. We're talking millions of Americans that are dealing with this disease, and they need to hear that it can get better. I don't have to just sit and die slowly. I can take action. I can take ownership.
You have autonomy.
Of my health.
You have control.
And again, if you are just fed up and want the quickest path to those positive outcomes, please go to empowerdiabetes.com. We can help. And we can help on a much accelerated timeline. So thank you for tuning in to the podcast. Please, again, like and subscribe, and we will talk to you again next week. So there you have it. This isn't just about a rush doctor's visit. It's about what comes after. If you've ever left an appointment feeling confused, dismayed, or overwhelmed, you are not alone. Diabetes care can be different. You deserve more than a 15-minute warning shot. You deserve a plan, a partner, and the power to change your story. Take courage. You can do this, and we can help.